Um, I'm going to talk about nail psoriasis. The prevalence of nail involvement in psoriatic patients varies between 15 to 80%. And nail lesions cause considerable discomfort for patients and adversely impact the quality of life. And there is a broad spectrum of nail dystrophy associated with psoriasis, and differential diagnosis between nail psoriasis and other nail dystrophy may be challenging. So, psoriasis may affect all the components of the nail unit, and diagnosis will be discussed as it affects all the components of the nail unit. It may involve each nail component in turn. And we start with nail matrix involvement. Nail matrix features include pitting, leukonychia, red spot in the lunula, and crumbling. Nail pits are superficial depression in the nail plate that move distally with nail growth. And nail pits are due to psoriasis of the proximal nail matrix that causes abnormal keratinization with the presence of parakeratotic cells in the uppermost surface of the nail plate. Pits are typically irregularly spaced and almost exclusively seen in the fingernails, with rare occurrence in the toenail. The number of pits is important when they are less than 20. They are non-specific for diagnosis, and when they are more than 60, it has been said to be diagnosis of psoriasis. Moreover, the incidence of nail pitting rises with increases in the severity of the disease. It has been shown that regular pitting could be converted to rippling or ridging. Both lines are a consequence of a sporadic irritation of the nail matrix and may spread to the nail plate, resulting in an important loss of the nail. So if nail pitting is highly characteristic of psoriasis, however, it may also be seen in lichen plan, eczema, and alopecia areata. Another nail matrix feature is onychomyiasis, which is the separation of the nail plate from the matrix area. It could be a sign of psoriasis and also as a side effect of retinoid used in psoriasis. Onychomyiasis has been associated with infection, autoimmune disease, critical illness, and medication. Another sign, psoriatic tracheonychia, it is characterized by a roughness of the nail surface, and tracheonychia may be related to lichen planus, alopecia areata, eczema, chemotherapy, ichthyosis. In psoriasis, the nail may be affected by true leukonychia due to involvement of the matrix by the middle and or distal part of the matrix. Leukonychia may be apparent due to onycholysis and be by parakeratosis and deposit in the nail bed. And we all know that leukonychia is a very common feature of onychomycosis. Punctate leukonychia is usually due to repeated minor trauma to the matrix. And here we have another sign of matrix involvement, which is a red spot in the lunula, which is the result of modification of the amount of blood beneath the nail. And red lunula could be seen in lichen, alopecia, and congenital or idiopathic. And now, let's move to the nail bed features. And the first one is subangular hyperkeratosis, which is an accumulation of scales beneath the nail plate. Subangular hyperkeratosis involves the distal nail bed and hyponychium. In psoriasis, subangular hyperkeratosis is usually silvery white, but may be yellow or greasy. Here, subangular hyperkeratosis, even if it looks like as pachyonychia. Subangular hyperkeratosis is most commonly found in nail psoriasis or ichthyosis and onychomycosis, although it may be so in eczema, lichen plants, Dari disease, and calciphylaxis. Eczema. Okay. Another sign, onycholysis is a nail bed feature. The detachment is due to a significant lesion at the hyponychium where parakeratosis interferes with the adhesion of the nail plate to the nail bed. This separation occurs along a convex line. An erythematous border around the onycholytic area is diagnostic for psoriasis and most frequently seen in fingernails. Bacteria and yeast may invade more easily in the presence of onycholysis. And the two main causes of onycholysis in the toenail are trauma and onychomycosis. Differentiating distal subangular onychomycosis from psoriasis is especially challenging in the toenail. So, other dermatological conditions causing onycholysis with predilection for the fingernail include eczema and also lichen. The oil drop salmon patch discoloration is a yellow rich brown drop that occurs in the nail bed and or the hyponychium. The oil drop may be seen in the central part of the nail, or it may surround an onycholytic area in the distal nail bed. Splinter hemorrhage also involve the nail bed and appear as teeny linear structure, usually not greater than 2-3 millimeter long, arranged in the long axis of the nail. Several conditions other than psoriasis may cause distal splinter hemorrhage. They can also be found in onychomycosis, eczema, trauma, and lichen. Psoriatic paronychia. This suggests that the scales formed and retained beneath the proximal nail fold act as foreign bodies. There is neither inflammatory cells nor fungal material. A chronic paronychia may be associated with nail infection caused by molds, pemphigus, acrodermatitis, and we can have double site involvement with different features, such as nail crumbling is a nail matrix feature is related to a thick and dystrophic nail plate as well as a hyperkeratotic nail bed. Additionally, crumbling is suggestive of a long duration of disease. Nail changes are seen in the different form of pustular psoriasis. Subangular abscess are frequent in the general form of Van Bush. It begins with one single digit where the distal phalanx comes red with pustule. Yes. Here we have a case of chronic candida. This is the evolution of our psoriasis during 2 years. And onychomycosis may mimic each type of presentation, and differentiating onychomycosis from psoriasis is especially challenging. In the two nails, it is important to consider the possible coexistence of both diseases, which was reported to occur in 50% of patients. For example, in this patient, he has two big toes. He has also psoriasis and onychomycosis. So onychomycosis can be distinguished by the presence of other nail findings, particularly yellow patches and stripes. A clinical diagnosis of nail psoriasis can be difficult as the symptoms are common feature of many nail disorders, and the presence of multiple signs in different nails is highly suggestive. So, some clues, multiple sign, different sign is highly suggestive. When you have more than 50 irregular pieces in the fingernail, onycholysis with a erythematous border and salmon patches in the nail bed. Also, the inefficiency of antimycotic treatment. Laboratory investigation is essential when the condition is restricted to the nails, and histopathology may be helpful. And the most frequently observed dermoscopic feature were splinter hemorrhage, pitting, and distal onychomycosis. So, take-home message. Nail psoriasis has several clinical manifestations depending on the anatomical location of the process within the nail apparatus. Pitting and onycholysis are the most common clinical manifestation of the nail psoriasis. About 1 to 5% of patients manifest with nail change only. A diagnosis of onychomycosis does not exclude nail psoriasis, as the two conditions are commonly associated. A good history is invaluable in determining the correct diagnosis. Exam of all 20 nails is always necessary, and general practitioners should be aware of some minor signs in the nails in order to diagnose nail psoriasis. Therefore, a correct diagnosis is the key to the implementation of successful treatment. And thank you. شكرا على حسن الاستماع.
Thank you, Dr.